What's up guys, Tony here. So in this video I want to jump into the Medicare benefit policy manual again. I want to look at the contents of the plan of care, and I want to kind of share some perspectives on the evaluation relative or compared to the plan of care, what you're doing now, what you could be doing, and how things might change for you if you just look at it from a different angle. So let's jump in. Let's take a look at the Medicare benefit policy manual. You can see here, this is page 163, the contents of the plan. So we need a diagnosis, and if you watched my last video, you know that if you're in a state that allows you to choose your own treatment diagnosis, that's what you do. Like, I had a situation where a patient was referred to me with Parkinson's, low back pain, right knee pain, and kind of a laundry list of other conditions. Based on my evaluation, I determined that, you know what, for this individual, the two biggest factors is going to be the difficulty walking, because there was a series of falls in his history, and the low back pain. And so those are my primary secondary diagnoses. Even though there was multiple other conditions on the referral, my primary focus for treatment for the plan of care were those two things. So if you have the ability to choose your treatment diagnosis, you know, another common one is somebody might have had a rotator cuff tear and they're coming to you after surgery. Well, you're not treating the rotator cuff tear. You're not providing the surgery. You're rehabbing the condition. So there's some post-surgical diagnosis codes out there, aftercare, that you can look into. WebPT has an article that kind of goes through a couple of them. But the idea is back to, if you have the ability within your State Practice Act to choose your diagnosis, then choose the most appropriate treatment diagnosis. If you don't, there are guidelines within Medicare, within this document, that help you figure out what you can do in terms of choosing a diagnosis. We need long-term goals, right? If you want short-term goals, if you want impairment goals, that's great, add it. This is not the only thing you can have. This is the minimum requirement of what you can have. So long-term treatment goals, those are generally going to be your functional goals, right? Being able to walk, being able to transfer, like all that kind of stuff. And then of course the type, the amount, the duration, the frequency. These three kind of bullet points are the main minimum required standards for a plan of care. Now you can add as much as you want on top of this, and you should be adding quite a bit more to support medical necessity, to help a reviewer understand why this patient needs the skills of a licensed clinician. Like, all of that can be on there. What I think is important, the reason why I wanted to bring up this video today, is because I want to talk about the difference between the evaluation and the plan of care. In order to provide treatment to a Medicare beneficiary, you need a certified plan of care. The provider needs to sign off on it. You can begin treatment on the day of the evaluation without a certified plan of care, but you have to get that plan of care certified. There's time frames within that, talks about it all in the document. I'm going to leave that for another video. But what Medicare tells us is that the evaluation can be a separate document from the plan of care. And I think that's really important, because I see providers get bogged down with this idea that we have to get everything done in the first session. You know, if I don't do this entire comprehensive physical therapy, occupational therapy, speech evaluation, if I don't get every little nook and cranny of information, then I can't proceed, right? And so they spend 60 minutes, 90 minutes, 120 minutes doing all this evaluative stuff. And what I would say is, while you need to get the bare minimum, you need to get enough to satisfy and complete your plan of care, your evaluation doesn't have to be done in a single session. The evaluation code, the CPT code that you're billing, let's take physical therapy as an example. Let's say 97161, 162, 163. They're not timed codes. So that means the time you spend before you ever see the patient face to face, collecting that patient information, collecting the past medical history, maybe over the phone, completing a pre-admission interview, right? All of that goes into building your evaluation. But then even once you see the patient, I've been doing this a long time. I'm generally confident in my ability to perform an evaluation, but I can tell you that I don't believe that in one session I can learn enough about an individual, about their case history, about their social history, about their cognitive function, you know, like all these factors that come into play. I don't think I can understand and fully appreciate all of that in a single session, the first time I meet this person. So my evaluation, while it starts before the patient ever walks in the door with the pre-admission, it continues on to that first session, the second session, the third session. I'd say reasonably by the third or fourth session, now I've got a pretty solid handle on what do I think is really going on in this person's history? What are the outside influencing factors that are affecting this person? And so my evaluation tends to be a living, breathing document that grows with time. My plan of care is done the first day. My plan of care is sent out to the referring provider, the physician, pretty much before the patient leaves my office on that first session. Like, it is done. But my evaluation continues to grow, and it continues to develop, and it continues to become more holistic, more robust as I get through some of the layers of, you know, fear and anxiety and pain and insecurity that the patient is bringing with them into my office, or for mobile PTs that when you're going into their home. You know as well as I do, that first impression, the patient's trying to impress you just like you're trying to impress them. It's not until you get past some of that that you really start to see some of the deeper rooted issues that might be influencing why this patient isn't healing, recovering, getting back to their premorbid status. And now you can start to get to the real root of the problem, the meat of the issue. So guys, I just wanted to say your plan of care, which needs to be certified, can be a separate document than your evaluation. And your evaluation does not have to be completed on that first session. The plan of care needs to be completed. The evaluation can be growing and added to, and just this living, breathing document. If you have more questions, if you want to share your experiences, if you think what I'm saying resonates with you and makes sense, and now you understand, okay, that 60-minute time spot, or 40 minutes, or 90 minutes, I can do more than I thought I could do because I thought I had to get all the evaluation stuff done. If any of that resonates with you, let me know. Leave a comment. Tell me how you structure that first interaction. Tell me if you are getting information in a pre-admission telephone call and adding that to the eval before you ever meet the patient. I would love to hear your system, because I think me and the rest of us would be able to pull nuggets of gold out of what you're doing, just like hopefully I'm providing you with a little bit of value sharing what I'm doing. Guys, as always, take a minute, subscribe to the channel, ring the notification bell, and I hope that I can help you grow your business, be more successful in private practice, and just understand the Medicare regulations a little bit better. I'll catch you in the next video.